Bipolar disorder is a highly heritable condition. Biological factors account for between 60 and 80% of an individual's risk of developing the disorder. Despite this high biological determinism, clinical diagnoses relies on observing behavioral phenotypes, a process that currently takes an average of 8 years. The World Health Organization ranks it as a leading cause of lost years of life and health for those aged 15 to 44. With a suicide risk 10 to 30 times higher than the general population, these diagnostic delays carry severe consequences. Current psychopharmacology often relies on reactive, trial-and-error treatment algorithms. These protocols frequently reach their limit when confronted with complex clinical presentations. To understand this limitation, we must examine the CANMAT and ISBD guidelines for the mixed features phenotype and the data from a recent 2.9 million participant genomic study. Effective management not only requires recognizing where phenotypic observation reaches a plateau and where genomic data provides the necessary resolution. The DSM-5 defines mixed features through the intersection of mood poles. This requires a syndromal manic or depressive episode occurring alongside at least 3 symptoms of the opposite pole. This framework replaces the previous DSM-4 mixed episode criteria, which required concurrent manic and depressive syndromes. Patients with mixed features face a difficult clinical course, including poorer response to acute treatment, less time in euthymia, and high longitudinal instability. Researchers from institutions like Johns Hopkins University helped develop the 2018 CANMAT and ISBD guidelines to address these specific complexities. These guidelines reveal a significant gap in treatment. No pharmacological agent currently meets the evidence threshold for a first-line recommendation in DSM-5-defined mixed episodes. First-line monotherapies used in standard bipolar 1 or 2 protocols, such as lithium or quetiapine, are often insufficient for resolving these mixed states. Because no agent is recommended as a first-line choice, psychiatrists must rely on second-line empirical strategies to manage the mixed phenotype. This clinical matrix categorizes agents by polarity. Column A focuses on mania presenting with mixed features. For this presentation, the level 2 and 3 second-line options include asenapine, cariprazine, divalproax, and aripiprazole. For the inverse presentation, depression plus mixed features, the evidence base narrows. The designated second-line options for this state are restricted to cariprazine and luridone. Cariprazine is the only agent with supported evidence for treating both manic and depressive mixed states. Luridone is also recommended for mixed depression, though clinicians note that the participants in its pivotal trials had low baseline mania scores. By contrast, under older DSM-4 criteria, asenapine and aripiprazole were considered first-line treatments. These dense, polarity-specific algorithms suggest that purely clinical observation has reached a therapeutic ceiling, requiring a pivot toward molecular insights. Scientists at the Icahn School of Medicine at Mount Sinai and within the Psychiatric Genomics Consortium recently analyzed genomic data from 2.9 million participants, including over 158,000 cases of bipolar disorder. This Manhattan plot identifies 298 specific regions of the genome where DNA variations are linked to an increased risk for the condition. By cross-referencing fine mapping and variant-to-gene mapping, the team identified 36 credible genes involved in the disorder's etiology. These genetic signals map to specific neurological targets, particularly GABAergic interneurons and medium spiny neurons within the prefrontal cortex and the hippocampus. The study also yielded systemic findings, showing that cells in the intestine and pancreas are involved in the disorder's genetic architecture. These findings indicate that bipolar disorder is a multi-system condition, extending beyond traditional neurological boundaries. These signals remained consistent across clinical, community-based, and self-reporting participant groups. Identifying these 36 genes characterizes bipolar disorder as a multi-system architecture rooted in specific brain cell types and metabolic organs. This genomic data is now being used to develop clinical tools for Staging 2.0, a precision psychiatry approach that uses biomarkers to inform treatment selection. This workflow utilizes genetic information to differentiate between lithium responders and non-responders. This prediction relies on polygenic risk scores, which provide a statistical probability based on an individual's cumulative genetic risk variance. Combining the polygenic risk scores for schizophrenia and major depression has been shown to improve the predictive accuracy of a patient's lithium response. Key markers for this calculation include diversity in the HLA-DRB1 and HLA-DQB1 genes. The study also found significant genetic signals for targets of calcium channel blockers, and signal enrichment was found in targets of anti-epileptic medications. This data provides a biological basis while identifying targets for future drug development. Integrating these scores allows clinicians to move toward a predictive model where genomic probability informs the selection of effective treatments. This architecture defines the current standard of care. Staging 1.0 represents our necessary reliance on phenotypic algorithms to guide treatment. Navigating mixed features still requires therapies like asinapine or divalproex as primary tools. Staging 2.0 represents these foundations integrated with genomic profiling. Mapping the 298 risk loci may eventually allow clinicians to identify biological shifts that occur before a manic or depressive episode begins. This genetic mapping can also help us identify patients who are at risk for treatment emergence switches, such as an antidepressant-induced mania. This approach tailors interventions to the specific neurobiology of the individual, moving beyond population-wide averages. The effective management of bipolar disorder now requires looking beyond the outward phenotype to address the underlying genome.